patients and not-for-profits interested in the SI joint may also participate. There have been a number of annual meetings, 2 of them in Germany in 2015 and 2016, another in Tampa in 2018. SIMEG has also had a joint symposium with ISAS in 2019 in Puerto Rico, and starting today in the setting of the COVID pandemic, we decided to start having webinars in lieu of the annual meeting. The idea being to have 1.5-hour meetings every other month rather than a 1.5-day symposium as we've normally done. We are planning on another annual meeting next year, but the final determination of that is pending based on circumstances. So why was SIMEG founded? It was founded because the SI joint is an area where there's tremendous disagreement about whether the disease even exists, much less how to treat it. Treatments in the past have been have had very poor results until the modern age of SI joint surgery, starting with posterior and lateral fusions for degenerative disease in the setting of a long history of treating from laterally for trauma. The number of articles continues to explode, now almost hyperbolically, and this was last updated in the end of July of 2018, and the number of articles is just going up dramatically. More and more people are accepting not only it's a real disease, but that there are legitimate treatments at this point. There's a confluence of articles emerging from lateral approaches that all seem to overlap with each other. And we are starting to get reports in a similar manner for posterior surgery, although clearly not nearly as well documented as for laterally. SIMEG itself has numerous goals for a society dedicated to the SI joint. And I won't go through the entire list. I think we need to get on with the educational part of the meeting, but we have educational goals. We want to evaluate factors that influence the outcomes of surgery, including the magnitude of improvement, variability, and durability of the outcomes. And these are general issues and surgical issues. And finally, focus on ways to improve quality of care. So for today's webinar, there are at least 17 different approaches to the SI joint, all of which have the same Achilles heel, which is how soft the sacral ala is in comparison to the ilium and other bones that are structural. And most devices tend to fail in that region. And so the approach we're talking about today is the dorsal recess approach. Our second webinar, and you can save the date, will be in about 2 months on September 9th, where David Pale and Vic Patel have agreed to do a similar talk of failures of SI joint surgery, this time from a lateral approach, including revision methods. So I'd like to turn it over at this point to Thomas Kibsgard to review the literature. Thank you.
Let's see. What screen do you see now? You don't see the presentation, do you?
Yes, we do.
Okay. Yeah, my name is Thomas Kibsgard. I met many of you before, and I was assigned to talk about the literature. Let's see. Last week I was in Lofoten, that's in Norway. This nice beach is usually crowded with the Germans, with motorhomes, but this year, thanks to Corona, it's empty and beautiful. I have no conflict of interest. I will start with a case. There's a woman from Eritrea, born in 1975, one child, pelvic pain during pregnancy, and every SI provocation test were positive, and she has a positive SI block. What can I say to her in 2017? I can say that she has a SI joint pain. I think an operation might help you. I operated 15 patients before, and I have no complication, and except for one, everybody else had significant decrease in pain and disability. There have been published a lot of studies with promising results, and they're comparable with my experience, but I cannot tell you about the durability yet. That's what I can say. So I operated her with a lateral approach with iFuse. I'm going to talk about dorsal dorsal approach today, but I will talk about every approach. So when you're going to look at the literature and what literature we're going to look at, there's so much to look at, and we're going to have a lot of webinars later to look into these areas, but there are so many things to look at. The inclusion criteria, patient selection, what is wrong, injection, how to do it, and all these types of implants, and we cannot actually tell which is best. And we have all these outcome measures that we can use. Are they good, and what will we ask the patients, and how do we measure the outcomes? I will actually look at more the strengths and limitation of the some of the literature we have, and see if we can actually trust it. Let's see. Sorry. One nice article, I've shown this before, why most published research findings are false. That's a nice article published in 2004. And of course, the small studies, they are less likely to be true. And if you have a small effect size, it's unlikely to be true. If you have a great number of tested relationships, it's less likely to be true. If you just throw out something and try to find a relationship, you might find something, but it's probably not true. If you're flexible in the design, the definition, and the outcomes, it's probably not going to be true. And if you have a great financial or other interests in the scientific field, it's less likely to be true. And if there's a hot scientific field, probably they're less likely to be true. Especially these two, last one, 5 and 6, is actually quite important in this talk. So I see it this way. There are 3 types of outcome in SI joint surgery for the surgeon. They're the happy patient with perfect implants, below to report them. And then we have the unhappy patients with perfect implants. Surgeons hate them because they made an error, even in the diagnosis or something. But it's okay for industry because the device was not the fault. And then we have the unhappy patient with implant-related complication. It's okay for the surgeon because they can say that the implant was the cause, but the industry and the shareholders, they think they tried to hide them. So how can we use the literature to help us hide our failures? And the happy patient with perfect implants, we can use them to hide the bad outcomes. If you have a mean, then you can hide a lot of bad outcomes. If you have an unhappy patient with perfect implants, you can the outcome can be hidden in the mean, and they can be lost to follow up. And if you have this unhappy patient with complications, so the outcome can be hidden in the mean or explained by, and the complication can maybe be explained by other causes, and what they call in the literature complication explained as non-device complication. This is actually a nice paper from Wiel and Duhon from 2019, and they are describing much of the current literature on sacral joint surgery. It's nicely written, easy to read, and it's quite balanced. And as you can see here, this is the visual analog pain scale. They start out with around 8, and then they go down to between 30 and 45. It's a nice curves. There's different types of implants, SIJ, symmetry, and these three. There's the iFuse implant. Most studies use VAS scale or ODI as a dependent variable, and only 2 of these studies has a control group. That's the 2 RCTs, and they usually report a mean. What's the problem with VAS or NRS, a numeric rating scale? It depends on what question do you ask. This is from my first 20 SI joint fusions. If you ask the patient what is the pelvic pain now, they scored an average of 42 or something. But if you ask them what is the pain in the SI joint, then it's quite different. It's much lower. That's the same with the unilateral surgery. If you ask them about the pelvic pain, it's much higher than the NRS on the operated side. So VAS scale or NRS are so dependent on what you asked. And if you read the papers, they usually do not report that. And the problem with the mean in my mind is that if you make a study of 10 patients and they start out with 8 in VAS, they are operated, and 12 months post-op, all patients have 2 in VAS, then the mean is 2. But 2 is super great, so you're satisfied with 4 or 5 or maybe 6, because you know that 2-point decrease is clinically important. So if you have 0 failures over here, then everybody has 2, and then the average is 2. If you have 1 failure, he has still 8, then the average is 2.6. If you have 2 failures, the average is a little bit higher. And if you go up to 60–70% failures here, the average is 5.6. So we can hide a lot of shit in the sack, actually, in the mean. So when I read these papers, I try to look for industrial bias, because if you read papers by people who have a financial interest, they maybe write it a little bit differently. And where have they hidden the failures? Because it's very hard to read the papers and find out how many failures and what happened to the failures. And what method have they used to hide their failures? So can I use it can I use these papers to treat my patients? That's an important question. And are there any complication I can learn from, and is the conclusion correct? It's all about internal and external validity. Internal validity is did the treatment cause the outcome to occur? Of course, there's problems we can do, mistakes we can do. There's a selection bias, sample size bias, confounding factors, dropouts, memory. In retrospective cases, it's hard to remember things that go wrong. And also fatigue or memory effect on questionnaires. If you've done these questionnaires 100 times, 3, 4, 5, 6 times, you may be tired of filling them out, or you remember the last one, what you said the last time. The external validity, can the findings apply to other groups? And of course, if you read the patient characteristics and inclusion criteria and exclusion criteria, you might find out if the patients are the right one, or if they're a different population. Is the study setting in the same as in the real world? Study-sponsored implants, maybe. There's something else that has changed. If there's old studies, maybe time has changed, so it doesn't apply to the time we're living in. These questions, we have to ask ourselves these questions. I think everybody knows about these 2 papers, so I'm not going to talk much about it. It's published by SIJ, and they are quite nice papers. There are 2 randomized controlled trials, and that's all we have. There's no other randomized controlled trials on this subject. And I looked at the clinical trials today, and it doesn't seem that the interest for doing randomized controlled trials on the subject is high. We're doing one in Norway, but I can't find anybody else on clinical trials now. If you look at these studies, the internal validity is quite high. They use VAS and see if they have surgery or not. But there might be other factors that influence these results. My largest concern is how was the study presented for the patients, since there were 80% crossover after 6 months. Maybe they didn't want to get well in the conservative group, I don't know. But they show that the conservative group do not have so much effect from this, but the SIJ infusion. We have seen this before, so it's not so important to report now. And there's maybe an industrial bias, of course, because they want to sell this product. The external validity, it seems like my SI joint patients, sounds like my patients, the results seem fair, it's not much better than mine. And but these patients, the patients on disability leave were excluded, and all my patients are on disability leave. So maybe I can't use it anyway. If you look at the European study, this is the 2-year follow-up. And as you can see, it's the same. The conservative group does first and the operated group. But if you read it, there's a 43% crossover from conservative management to a SIJ infusion group. And they use something called last observation carried forward approach. That's the last observation before crossover are used later at the time points. So if all the crossover were bad, it can actually camouflage some of the effect of the other conservative treated patients. I found also a comparative study of RIALTO versus IFUs, and if you look at the conclusion, both IFUs and RIALTO offers a significant improvement in pain and disability and quality of life. However, there's no difference between the devices, and the increased revision rates in RIALTO group warrant further investigation. That's the conclusion. But let's look at the data. There are 2 groups. It seemed quite comparable, it seemed quite alike, but these are not randomized and are not matched, so we don't know that these 2 groups are alike. And if you look at the outcome, this is the 1-year outcome. This is a VAS-back, down 2.8% in IFUs, in RIALTO 2.4% in 2.4 points in the IFUs group, and the ODI has decreased by some points. But you also know that the minimal clinical important difference in groups should probably be 10 to 15. So it's probably a statistical significant change, but not clinical of clinical importance. The same as VAS is almost 2. If you look at the numbers of the outcome, the VAS-back scale started at 8 and went down to 5.8. And there's quite a large standard deviation as well. And if you remember my study about the mean, 5.8 can hide a lot of bad outcomes. If you look at the revision rate, 6 in the RIALTO group and 2 in the IFUs group is not a statistical difference. So when the conclusion is that the device offers significant improvement in disability. I don't think it's quite right, because it's not a clinical important difference, it's a statistical difference. And the increased revision rate, there were no statistical difference in the revision rate, so why do you need to have some especially warrant for further investigation of the RIALTO? I don't know. Maybe it's because this guy is a consultant for SIJ. Maybe there's an industrial bias here. If you look at the dorsal approach, Volker Fuchs published a study. Maybe he's going to talk about it later, so I'm not going to talk much about it. It's an observational study, 20 centers in Germany over a 6-month period. All patients were included. They also excluded the ones with disability leave. And if you look at the outcomes here, there's a decrease in all the outcomes, and it included also the reoperation, which were 4.4%, and there was only one complication in the group. It depends on what you call complication, because when you're reoperated, that might be a complication. So, but during surgery, there were only one complication. The pain went from 63 to 36 with a quite large standard deviation, so maybe there are some failures here as well. The fine thing about the observational study, they can look at some other aspects of the diagnosis, because they used pain diagrams, and the typical pain drawing with some localized pain of the SI joint, they did much better than the generalized pain diagrams. And that might be important when we treat these patients. When I opened when you open the journal and see a paper like this, I don't know. It's 160 patients follow up at 3, 6, 9, and 12 months. Vision analog scale went from 8 to 2.5, and the ODI went way down, and the clinically important improvement was 95%. Of course, this is also a SI bone guy. There were no reoperations, and 63% had prior spinal surgery, 23 had nerve stimulator, had 70 minutes operation time, some hematomas, and no complication with the implant. It's so much better than me, and there are no failures here. But this graph, what does it show? It shows the follow-up. So near half the patients disappeared for the 12 months follow-up. And so maybe there are some failures hidden in the dropouts, actually. I don't know. But in the discussion, they stated that the 12 months follow-up rate in our group was high. I don't think 50% follow-up is high. Of course, then we have a paper with no disclosure, no industrial bias. That's a 6-year comparative case series by Vanna Cloca from Spain. And it shows that the conservative management and the SI degeneration do not help, and the SI fusion help. But if you look at the follow-up, they started out with 27 patients, and when the time goes by, they drop out, and the 6-year follow-up is 1 patient. I don't think that's representative for the whole group. I think it's hard to conclude with this study, because there's several studies with severe limitation to the internal external validity, and we need more studies still. So when my patient, she was fine for 6 months, and then she came back with the same pain. And on CT scan, we saw lucency. And what do I say now? What does the literature tell me? And when you look at in the literature, I can't find anything about it. So then you're actually all by yourself. The literature says that I'm a bad surgeon because the prevalence of revision is so low. If you look at the randomized controlled trials, they had in the American study 22 events related to the device, 4 revisions, 1 nerve impingement, 1 fracture, 1 loosening, 1 misplaced implant. So when I have 1 loosening, it's very rare. The same in the European study. If you look at the post-market complaints database for SI joint and IFUs, they have 5,000 patients, 1.8% revision rate. Late revision was 0.6. I think it's low. I don't know. But when you look at the other data, the device-related events, there is some pin bending and pin advancement. I operated 2 patients yesterday, and I had 5 pin advancements. And in this study, in 5,000 patients, they have 14 pin advancement, and I have 5 in 2 patients. So I think these data are not correct and probably too low. So I don't know if the revision rate is so low. If they look at the survivorship of the IFUs as well, for a year down the road, the revision rate is 3.8. Probably, I maybe think it's higher. I don't know. I don't know how this data was collected. If you look at this study from 2017, they compared the fixation with screws and IFUs. Of course, screws they loosened, and IFUs had a revision rate of 4.4%. This also was a study sponsored by SIJ. And for the RIALTO, 6 out of 70 had it's way under 10%. 6% was it. So it's quite low. If you look at my reoperations, I have done 100 cases, 6 RIALTO and 94 IFUs, and I had 1 gluteal artery bleeding in an Ehlers-Danlos patient, and 1 misplaced implant, 5 loosening actually, and 1 ilium fracture. You can see it over here with fractures right through the implants, and 1 recurrence of pain, and I thought it was loosening, but I reoperated her with bone packing and RIALTO, and she was fine, but the implant wasn't loose. So this was not an overview, but more like thoughts about the literature, and the clinical failure rate varies, and I think we still have a long way to go to avoid the failures, and I think they exist. And we need more independent studies, and maybe change focus from excellent, acceptable means to a description of our failures. I don't know if you have any thoughts about this. That was all I wanted to say today. We can open for some discussions.
I'd like to add a few more thoughts to that. Another way to camouflage things is to report standard error instead of standard deviation, and that's commonly being done right now. And yeah. I've talked to authors that have done that. That makes the variability look much worse or much better than it really is. So I think all studies need to report in a standard way, typical of science, which is standard deviation, not the standard error. Number 2, I think we should all report our findings 2 different ways. The group, average with means and standard deviations, but also the number of patients that have greater than 50% improvement, which is beyond a typically accepted placebo effect. So then you know the number of responders that we can compare between studies. And then third, there should be a Christmas tree or scatter plot showing the actual individual patients, so you can look in a diagram and see how much variability there is, so that people can have a good idea how that particular device responds in terms of its variability of outcomes. And I think there's a huge amount of variability, particularly in this field. Are there any other comments or questions?
Hi, David Pauly here. Thomas, thank you for that presentation. I appreciate the ability to dissect down potential problems. And I think that the issue of failure is probably more difficult to track down than the issue of success. So I completely agree with a lot of your statements. And I've been trying to understand how to think about the total joint arthroplasty revision literature and how we should look at that in relation to the SI literature. And that we have finished some initial work in looking at about 50 revision cases at the University of Minnesota of many different types of devices. Mark Swinkowski and I are in the process of writing that up with one of our residents right now. And the lessons that I've had about failure have been several-fold. Number one, whenever I've removed implants, be it from a dorsal or a lateral approach, they've all been pretty well fixed to the ilium unless they were malpositioned. Yet it's been the sacral side where they've not grown in. And so once you chisel through the ilium, they pull out easily. If you try to pull them out without chiseling through the ilium, they don't pull out easily. But Vic Patel got me thinking about pain patterns a little bit differently, as did Zazdak. And that is that I've had one or two ankylosing spondylitis patients that I've operated on, well-positioned, appearing well-fixed implants that didn't get any better. And it made me think that the etiology was an immunologic response against the cartilage, and that we hadn't completely eradicated the cartilage, so it made sense that they still hurt. So that made me think about the patient with well-fixed implants but persisting pain. And so my approach to that has been, right or wrong, to do a CT-guided local anesthetic injection to see if it relieves the pain. And if it relieves the pain, then presumptively, in my mind, there's still something going on, typically in the caudal aspect of the SI joint. And so Vic made me think about that in a different way. And I've had, I think, 6 patients now where I've drilled out the caudal SI joint and bone grafted it. And 3 of them seem to have positive response, and I can't comment on the other 3. And so when I think about failures, I think about, as you said, failure of selection. So the person who has pain everywhere and has generalized pain behaviors, the probability that we're going to make them better is not good. There's probably something about the chronicity of the pain that at least on fMRI, acute pain appears in one place and chronic pain appears more linked to depression. And so there may be, I call it upregulating of circuitry to cause a reverberating circuit to establish a pain behavior. And then have we adequately addressed the reason that the joint itself is hurting? And that sometimes we do that with adequate fixation and sometimes we don't. So I very much agree with you about struggling with the failure rates, and that sorting out someone who still hurts, who has implants across their SI joint, is challenging in my mind in a number of ways. And then how you define success in a revision strategy versus a primary strategy, I think is also significantly challenging. But I wanted to say thank you for your honest and appropriately challenging presentation to us about what does the data mean. Thank you.
Yeah, if I could just make a comment.
Shoot.
Is it coming through?
Yes, go ahead.
Yes, yeah, I agree. Thomas, that was really a great effort and presentation. And I think to David's point, I kind of think of the SI joint pain almost like patients who come in with back pain from a certain segment of their spine. And I agree, there's a group who have instability and you can do a posterolateral fusion and stabilize them and they'll probably do okay. Then I think there's a group who have the discogenic pain that is very chemically oriented, as you know, a lot of different cytokines that trigger a very painful disc. And if you do a posterolateral fusion, you may not get those people better, especially if their pain occurs when they're at rest. I don't know how you're going to do a fusion and really make it better than just lying down. So that's how I kind of look at that group. And honestly, I primarily only do interbody or combined fusions for my discogenic patients because I want to have the best chance that I'm going to get everybody better, not just the ones who are, have an instability pattern. And therefore, I like to take out the cartilage of the joint and do a true fusion.
We know that.
I thought I had that.
There's another issue buried in the reporting. Some people are quick to tell their patients, well, if it doesn't work, at least I won't make you worse. But in fact, that's not true. In that there are some patients in some studies where they're walking and working before the trial, and then after the implant, not only do they not get better, but they're not able to, they're wheelchair bound. So you actually can get worse. And that's variability that is maybe just small sizes between studies, but also may be a real finding that we need to observe. So I think all of this points to something that Martin has been thinking about, and I think David Polly has been thinking about, and all of us know needs to be done, which is finding a way to have an international consortium and agreement on how to report our data and follow it and have access to the data as a group for academic purposes. Are there any other questions before we move on to Martin or comments? Okay, so Martin Blay is now going to speak on his cases.
Bengt Sturesson. Okay, sorry.
Come on, Bengt.
Yes, I have one opinion. It's very good and important to follow the cases in a good way, and it took me a long time to make it possible to put my patient in the Swedish spine register. In the beginning, it was said that the sacroiliac joint is not part of the spine, but still it is the lowest part of the spine. So now everybody is followed in the spine register. However, there is a problem. And the problem is that some patients, they have also pain from the spine. So even though they are healed or they are improved in the sacroiliac joint, they can start to develop pain in the lumbar spine as well. So what will I say? Yes, I think it's very important that we have a sacroiliac register, but it's also important to be sure that it's the pain that the patient is reporting, if it's coming from the pelvis or from the lumbar spine. Thomas, you showed very well patients who showed pelvic pain, and they had more pain compared to those who had to report the right or the left sacroiliac. So it is really tricky to be sure what you report about. But still, I think it's important with the patient-reported outcome prompts. It's patients are better than doctors. That is my first opinion. And second is about failures. I think it's even more important to report failures and to report revisions, because they are very infrequent. I think I have done about 400 cases, and I did on my patients 5 or maybe 6 revisions. So that's a very low amount, but still it's important to have a place also to report them, not only to the company where I have to report every revision, but also to the open, how to say, arena, to SIMEG, for example. Thank you.
Martin, are you ready? We don't hear you. Martin?
Oh, now you can hear me.
Yeah.
Happy to be able to talk on this new on this new medium about the topic we have already heard, and it doesn't work so far. How can I? This way. I have been a former tutor of Cygnus, so this is the only disclosure I have to do. And so what we'll learn in this webinar, we will learn how we as a board will learn how to make and improve webinars, because we didn't do this so far. We need to discuss difficulties in diagnosing, I will show the case with a series of different types of therapy in one patient, different types of primary surgical therapy, and the Revison strategies we have heard before. And what I learned is the English word for this. And then we will hear what are our next steps, what SIMEG is planning. So this is who we'll get to know during this session. It's Diana, the goddess of hunting. That's a bridge in Italy, where most of us know. This is the board. You have seen all of us, and that's me. And again, this device. We tried to start this session to keep as much doctors aware of our group and our ideas. Me and Volker will show some cases, and Tom did already, so we changed the follow. So Tom did already talk about the literature. And we will have the audience be asked to give some comments and discussions. I will talk about two things. One is Nadia or Diana, which is kind of similar, and the RIALTO. And for those who are not familiar with the techniques, this is Nadia, this is Diana. The difference is the surface of the screw. The screw is otherwise basically the same. It's a posterior axis. It's a kind of extra-articular arthrodesis that's going to be approached. And we have the RIALTO technique, where you start from the posterior superior spine, iliac crest, and you travel across the recess into the sacrum to make a transfixation. The screws are filled with bone, and the hope is that there will be a true fusion from ilium to sacrum. And in the other technique, Diana or Nadia, you really put a lot of bone in the recess, and the screw is only the device to make an arthrodesis possible. So I've got one case that I think it's interesting to share. It's a woman, because she's from Switzerland, let's call her Heidi. And she's born in '84. She has a family with 3 little children, and she's doing jogging, and she's a housewife. So no heavy profession. The pregnancies and the delivery were without any pain. And she started to have symptoms in 2014, which just were there for some weeks, or posterior pelvis pain, and was self-limiting, did disappear. Then she had a fall while she was on the bike with a very low speed and low energy, and fell on her right buttock. And then the same pain came again, and it did never go away. And it started to do some kind of radiating down into the leg, which was increasing. So she had a right-sided buttock pain radiating down the leg. And she had different opinions and doctors and diagnostics, and had done a spinal surgery that was done despite only a minor change on MRI. So someone did think the decompression of L5S1 might help, but it didn't change her pain. And then she had a series of infiltrations and percutaneous denervation of SI joint with help only for a short period of time. She lives here in the center of Switzerland, Lucerne. Then she saw some people in the capital in Bern, and she saw some people at Basel, and so she was traveling around quite a while. Then she heard of some doctor in Munich, so she went there, and then she came back with an idea of having a surgery, and was looking up for who's doing what type of surgery, and then she came to me. I'm located here at the Lake of Constance. To understand the case and my decisions, I think you have to know what I do, because I think everybody does what he can and where he's experienced. And so I'm an orthopedic surgeon in Switzerland. I'm not doing any type of degenerative spine. So I'm focusing on the lower extremity. So I do hip and knee prosthesis. I do osteotomies and all these things. So I look on the problem from below and not from above. Maybe this is a different view. And so my first contact with the SI joint was in 2009 with the Diana, where I met John Stark, and started with Dianas in 2012. I think I've done about 45 Dianas, and I was getting tired of the long recovery time they needed, and so I was looking for something else. I hooked up with some guy from Munich who is doing the multi-site from Joymax, the endoscopic denervation. And I had heard a talk about the RIALTO, and was pretty happy about the idea that they don't need crutches and that they improve pretty fast after surgery. That's what I was told. So I tried to have these two things in my toolbox, and was happy to have that. And so there was this lady, and again, this is winter 14 where the pain began, and the fall with the bike where the pain came back again. And then she had that MRI, she had the decompression of the spine without any changes, the infiltrations of the SI joint, the lumbar spine infiltrations, and some neuroablation of the L5S1. And then she saw the guy in Munich who told her to have an IFUs done, because that's what he learned. And at that time, she almost used everything that she could get on the market concerning pain medication. And she was very, very unhappy. And it was difficult for her to do the travel from Switzerland to Munich and back. So she was laying flat in the trunk of the car to do that. And so I was thinking, what could I do with this lady? She was in severe pain. She was very unhappy. I think she was not a good candidate for walk on crutches for several reasons. And so I thought, is the diagnosis correct? Yes, I think so, because she had some SI joint infiltrations which helped her pretty well, much more than 50%. And I think she had enough conservative treatment with a lot of physical therapy and all the other stuff. So I think some type of surgery could be the next options, but what type of surgery? And as I learned the multi-site procedure half a year ahead, I think she would be a good patient, because there's not a lot of harm I do to the patient, and she could walk without crutches and all these things. So maybe this would help her for the first time. And she was not a heavy smoke, but she was smoking at least a pack a day. So I was thinking to stop smoking with her and do arthrodesis later on. This was December in 2019. And so we did the procedure on one side, on the right side. And after that, she was kind of happy with this side, but she knew that this is maybe just helping for some months. So she decided to have something else, a definitive surgery with arthrodesis or stabilization on the other side, so the left side. And as I learned the RIALTO, I thought this is a very easy access to enter the bone here, to find this way down there and place the screw. It's easy to revise. That was my idea. And my idea was to have something in the recess if I need to have a revision. And so I offered her the RIALTO procedure, and we did the first side so she was innervated on the right side, she had fusion on the left side. And she was stopping the smoking. And then after 2 months, she was getting more pain on the right side. So she asked me to have a RIALTO procedure done on the other side because she was happy with the first RIALTO. And so we did this, and she ended up like this. And then she told, after the surgery, she said that she feels like this in the pelvic region, like very, very stiff, like in a bench vise. And this lasted for 2 to 3 weeks. And then she was happy. She was feeling really well, had no pain, and was happy after really 2 or 3 years of 2 years of pain. But this only lasted for maybe 2 to 3 weeks. And then pain was coming back again. And then she had an X-ray and CT scan, sent it to my office. And this is what we could see on her left side, that there were some of these signs for loosening. The other side was still looking okay. Maybe some change is starting here. And the CT scan showed the same. It's a sacral problem. And the iliac side, I think, was quite good. So, and in this phase, she was almost bound to the wheelchair. There, she was having troubles with walking with crutches, and had massive pain. And so, what to do now? So, go back to what I thought at the very beginning. If I have to revise, I switch from the RIALTO to something in the recess. I switched over to Nadia. So these were my first Nadias I was doing in April of this year. It was kind of pretty easy to get the RIALTOs out. So it was just one little turning, and then it was getting loose. I think it was there was a good healing in the ilium part, but no healing in the sacral part. And I took these out. I placed Nadia in the known technique, and this is how it looked like. So maybe the screw could be advanced a little bit more. This is the not operated side. And then she was getting better on the revised left side and still had pain on the other side. I saw, and just for the what to do, because she was happy with the revised side, I did the same revision on the other side. And then we see that this was in July 19. And since then she improved. She's now only takes NSAR some little, maybe 2 or 3 tablets a week. And she's improving with core stability. These are pictures from last week. She's very happy. She's has almost no pain during the day, and has problems in the upper spine, around the scapula, maybe from getting more and more active. And she's very happy from the pelvic side. So this is my story about this lady. And so to be discussed, I think it's always a trouble to find the right diagnosis, because people sometimes have other pain generators, and it's hard to distinguish between them. What do we offer to the patient? We have some different tools that we can use. Every one of the tools has some advantages and disadvantages, so we have to find a good way to offer different tools. I think we have to discuss endoscopic innervations. Are they useful? Are they useful more for finding the diagnosis or for therapy? I've done about 8 RIALTOs so far. I don't think I'm very happy with this technique. There's about 2 or 3 which are very happy. I have to revise both sides from this lady, and there's another patient with a bilateral RIALTO, which he's not very happy, but at the moment he is not willing to do any diagnosis, any diagnostics. We can get a true arthrodesis with Diana or Nadia, which I think is something that will help for the long run. Maybe we'll see this in a registry. And the after treatment, after a different type of surgery, needs to be discussed. I think Nadia and Diana, it's tough because of the consequent partial weight bearing and the limitations in function. So this is a really exhausting type of therapy. So if we have something else, that would be helpful. That's my input. Thank you.
Are there any questions or concerns? Martin, I noticed that the left implant on the first CT looked quite good, and on the second one, there was a lucency, but she was better clinically. Could you comment on that?
Well, the latest pictures I have is one CT scan. It's the same CT. I do not have another one because she's doing fine. So far I didn't do another one. She's now a little more than a year. And because of Corona and all these things, I didn't do a 1 year follow-up. But maybe I have to do this, or I think I will have, she knows that I want to have a CT scan during the next month. So when she travels to my office, I will have a CT scan the next time and I can show it. So the CT scan that you see, it's all from the same. So are you talking about the situation? Let me go back.
The first Nadia, you put it on the left side. You showed a CAT scan afterwards where there was no lucency. Then you showed a CAT scan where you had two Nadias, one on each side.
Okay.
And the left, which did not have a lucency initially, now is a year out, more or less.
No, this is done after this. It's May 31st. It's some only. Let me see. The first Nadia was. The first revision was done in end of April, and the second was done 8th of May. So the second CT scan that you saw it's just 5 weeks after the first surgery.
Ah, okay.
So this is not a real follow-up. It's a very early CT scan.
And the guy we met in Tampa, was it Ibrahim or something that had published on this?
Yes.
He tells us that he has excellent results. Are there anyone else that have used innervation for treatment or as a joint pain? I have no experience with it.
So I don't do it personally. I've had several of my patients have it done, and it strikes me that dorsal rami pain is different than articular pain, and that the people who respond to the radiofrequency ablation seem to be more of a sacroiliac patient than a sacroiliac pain patient to me. But I don't have any experience with the JOIMAC, so I can't comment on that. But the ablation responders seem qualitatively different to me than the surgery responders.
I think one thing that will emerge with time is that, in my experience with the Diana, many patients with bilateral pain, if you fuse the worst side first, the other side gets better. And very often I will wait for 9 months until it's fused before going to the second side to operate, because very often they get better. I don't know, David, what has been your experience with SI bone when people have bilateral? Do you need to fix both sides in almost every case, or is that a small subset?
Yeah, so what I tell them up front is statistically somewhere around 30% of the people who get unilateral fusions in my hands end up with bilateral fusions. And I've had some contralateral sides getting better and contralateral sides getting worse, especially with the COTS weight bearing for 3 weeks after. Almost always seem to flare the and so I've seen that happen, but I can't I can't give you a specific experience about percentage of people who get the contralateral side better. And at least as I understand the biomechanical data, it doesn't biomechanically explain unilateral fusion doesn't biomechanically explain why the contralateral side should improve.
We don't hear you, Thomas.
Unlike knees and hips, where there's a 90 to 95% success rate, I don't think any of us have broken the 80% success rate barrier. So I think there's a lot of different variables we have to focus on. And I think that'll be a really good thing to work on each of these symposiums. What are our opportunities for improving? And I think I'll leave it at that. There's certainly a lot more to do to improve our reproducibility and decrease our variability. So let's move on to Volker Fuchs with some more cases and his thoughts.
Volker, we don't hear you.
Can you see my presentation?
Yes.
Okay. So today I'm talking also about failures with the Diana implant. And I'm doing this also a long time, since 2010. So I also experienced, unfortunately, some cases I had to revise. So these are my disclosures. I was a primary investigator in Cygnus clinical trials. I did the German-speaking clinical trial for the Diana implant, and I also was a paid consultant of Cygnus, but not now anymore. So today the content of my talk is just a short introduction to the Diana implant or the Diana operation. Then we talk about reasons for revision. Then I want to give you some tips to prevent those revisions. And then I will end with 5 revision cases I did by myself. So the Diana, it's not a name, it's just a short form for distraction interference arthrodesis with neurovascular anticipation. And the Diana implant is just inserted inside the recess in between the ilium and the sacrum after those posterior sacroiliac ligaments and this interosseous ligaments are removed, and the recess is grafted inside the Diana implant and around the Diana implant. This is what it should look like after the surgery in the CT scan, and just a short run through the surgical procedure. You start with a guide pin inside the recess, and you have 3 C-arm projections that give you safe guidance for the guide pin. It's an AP and an oblique and a lateral shot. And then you go for the distraction, and you size the implant with a distraction maneuver. So you just distract the ilium against the sacrum, as you can see here. And then after this, you go in with a cutter and you cut the implant bed, and then you go for the implant insertion. We have advantages and disadvantages with the Diana system. The advantages, it's a tissue preserving surgical approach. So there's no risk for nerves or vessels, and even also not much for the bone. And because of the distraction and the ligamentotexis, you have the possibility of reposition of the joint in case you have a subluxated joint. And you have a lot of bone graft in and around the implant, and that's why it's not only a transfixation, but if it's working, it's a true arthrodesis of the sacroiliac joint. And it's also easy to revise. So in case of a pseudoarthrosis, for example, you get there very easily. But you also have disadvantages, of course. It's a round implant and it's just a single implant, and it gives you only a short time for primary stabilization. And this lasts about 4 to 6 weeks. And also because it's a round implant, you have high pressure forces on the ilium and on the sacrum. Because you need this bone growth and this true arthrodesis, you can't not rely only on the implant. You have to do a thorough preparation of the recess. And if you don't do this, you will end up in a pseudoarthrosis. And you are, or this procedure is relying on the bone graft, and the bone graft needs to be vitalized in the human body or in your patient. If this is not coming true, then you end up also in a pseudoarthrosis. And the implant has some disadvantage that it has no osseointegrative surface like we know it from other implants, like in hip surgery, for example. So this changed when the Nadia implant came onto the market. Now we have a porous coated surface. It's plasma sprayed, and there's hydroxyl apatite onto the implant. So it's not, like I said, you have now an osseointegrative surface, but I don't have much experience with the implant. I only did 3 of them. They did well, but they're only 3. So what are the revision risks and the reasons for revision? So in first line, we see an insufficient preparation and grafting of the recess. Second, often you have a revision due to an implant misplacement, and this comes out of an aggressive preparation, or due to a wrong interpretation of those 3 C-arm projections intraoperatively. And of course, you have anatomical variations. Because you go inside the recess, you have to deal sometimes with the S1 pedicle screw. You have to know if it's in your way when you go down to the recess or not. And like in any other operations, we have to deal with osteoporosis, infection, and pseudoarthrosis. So this is an example for insufficient preparation and grafting. You see here the implant in all 3 dimensions, and you see here above and below, inside the recess, no bone graft, just inside the implant and behind the implant, but not here above and below. Also a little tricky to prepare the recess is because you have transverse processes here, S1, S2, S3, and you have also, like in this case, not a very good preparation between the S2 and the S3 transverse process. It was not done properly. Here, just to show you the S1, S2 transverse process and this cavity in between those 2 processes, and also the smaller cavity between the S2 and the S3 transverse process. Also, wrong implant placement, of course, is a reason for revision and for a pseudoarthrosis or for non-arthrodesis. And like you see it here, it can be too far into the ilium and missed almost the whole recess. This is, or this would have been the correct position, or the other way around, too far into the sacrum. This would have been also the correct positioning of the implant. But you can also go, of course, too far caudal, like you see it here on the left side. The right side is well done, but the left side is in totally wrong position, or like in this patient, too far lateral into the ilium. So the biggest mistake I ever saw was this one. So it was put much too far anterior, and this would be the correct position. And there, right there, where the implant just is ending up, is the L5 and the S1 nerve root, and also the superior gluteal artery. Luckily, there was no nerve damage or vessel damage recorded in this case, but it could be. And also, if you go too far inferior with the implant, you end up quite near the sciatic notch. And you see it here in this example. If you look at the picture here below, you see that it's only 1.6 centimeters outside the bone. So this would be the correct trajectory. This would be the correct position here. And you remember the nerves and the vessel in front, like I told you, so you're close. This is another case where the implant was put too far inferior, and if you look closely with the guide pin, the cortical wall was hurt here, right here, towards the sciatic notch. So this could be giving harm to the nerves and vessels. But you also have to think of anatomical variations, like in this case, it's a bossing of the ilium on both sides. And if you don't look at this closely in the preoperative CT scan, you might miss a good preparation of the recess. You just prepare it like this, and you miss the rest of the recess and don't prepare it and don't graft it. This is another case for just a small bossing of the ilium, and if you look closely, or the implant was not put deep enough inside the recess, and if you look closely, it's just like this small bone spur here from the ilium reaching almost to the sacrum, that just gives the imagination to the surgeon that he is on the bottom of the recess, but he wasn't. So that's why the implant is not put deep enough inside the recess, and the recess was also not prepared well enough. Also, anatomical variations, like you see in this case, you have an almost normal recess on the right side and a very shallow recess and a long joint on the left side. Both sides are, here you see it's osteoarthritis on both sides, but this also can give you a hard time when you prepare the recess and you don't look preoperatively close enough at your CT scan. In this case, you have to go a little bit further inside the ilium that you get a good and proper implant placement. So if you have a fusion done before the SI joint arthrodesis with the Diana implant, you also have to look at the lumbosacral level, at the rods and the screws, especially in S1, because they could be right in your way, going inside the recess like you see it here. If you want to do a fusion, in this case, you have to take out the S1 screw and the rod. Otherwise, you end up like in this case where it was not done and the implant was just put down into the ilium and not inside the recess, and too far anterior, too far lateral. So this is not a good option to do so. And you also have to look at the CT scan because of the osteoporosis. Like we heard, the ilium is much harder than the sacrum, and in the sacrum you have sometimes a very severe osteoporosis or very low bone density, and you see even here not a cortical wall on this side or the almost hollow bone on both sides of the sacrum. This is an example for an infection. You see in an infection case, you see also that the joint there's there's also a bone defect then inside the joint, not only around the implant, but also inside the joint. And if you see this, you always have to think of an infection and not only of a loosening due to pseudarthrosis, of a non-healing pseudarthrosis. So this is a case of a pseudarthrosis. You see here lucency around the implant. You see on the ilial side, on the sacral side, you also see again a vacuum phenomenon inside the joint. And if you look closely also at the X-ray, you see the lucency on the sacral and ilial side, also on the X-ray of the pelvis. So what are the solutions for this, especially for now, first, the insufficient preparation and grafting? You have to use microscope or loops for preparation of the recess. Otherwise, you won't see it properly. You don't have enough light inside. So you should do this. And just stay away from the soft bone of the sacral side. Just start on the ilial side, then go down, visualize the joint line, prepare then the cavities between the S1, S2, and S2 and S3 transverse process thoroughly. Prepare the recess not only in the upper part or lower part, but in the full extent. And this is just an example. This is a CT scan of some of my patients. So just start at the ilial side, go down to the joint line, then move up on the sacral side, and just be aware of those cavities here inside between the S1, S2, and here between the S2 and the S3 transverse process. The joint line is running down there. You can visualize the joint line, and if you can see it, then you know that you have to put the guide pin a little bit to the ilial side, and this is your entry point and the correct trajectory for your guide pin. So, talking about the aggressive preparation or the wrong interpretation of the X-ray intraoperatively, it's quite easy to interpret it, those three shots. You see it here. You always have to stay with the trajectory inside the bone, inside the iliac column or the iliac corridor, in between the sciatic notch and the arcuate line. And this is true for all those three shots in the OR. And if you do this, you will always stay safe and you always have a correct implant position. But you also can estimate the angulation of the C-arm position of the oblique shot. If you look at the preoperative CT scan, you can do it here in a paraaxial reconstruction. And you see here that the C-arm positioning of the oblique shot would be around 35 degrees. So talking again about anatomical variations, you have to look closely because of those bossings of the ilium, and these are not so rare. So watch out for those ilial bossings. You have to look out for the S1 screw, as we already said, and you have to look out for the osteoporosis, because in osteoporotic cases, you have to be very, very careful in preparing the recess, because you will end up otherwise inside the ilium or the sacrum. Also, you can, of course, estimate in the preoperative CT scan what kind of implant size you need. Like in this case, you have a recess of around 16 millimeter, and you will end up with an implant 70 millimeters or higher, because you don't know how much distraction you can add. You can't measure it, or measure this distraction, of course, not in the preoperative CT scan. Talking about the correct entry point of the guide pin, you can also estimate this in the preoperative CT scan. Like in this case, for example, you have the parasagittal and the paraaxial reconstructions, and you have this correct trajectory down the iliac column. And if you move this reconstructed or this parasagittal plane back to the midline, then you see that the correct entry point in the lateral U would be right between the S1 and the S2 vertebra at the disc space. Another example here, doing the same thing, correct trajectory in the parasagittal and paraxial reconstruction, moving it back towards the midline. And you see here, in this case, you end up right in the middle of the S2 vertebra. So different to the case I showed you before. So now, talking about some of my worst revision cases. Case 1, female patient, 50 years old, bilateral SI joint pain. She was doing worse on the right side. That's why we started with the right side. We had an inpatient treatment. We did CT-guided infiltrations. And then we did SI joint fusion on the right side with a Diana implant, 17 millimeter. And she was doing fine. And because of the pain on the other side, she wanted to have the fusion also on the left side. And this was this was the patient where I saw the hugest recess in my life. And I've seen many hundreds. So I had to put in a Diana 19 millimeter, and I thought, well, maybe it's not big enough. So a couple of months later, we had to do a revision, also with the revision implant. Remember, it was a very, very big recess because it didn't heal, and I will show you the pictures. And then it didn't heal again, and we had to do a second revision together with dibutamin alpha, so BMP. And then I sent her away because I didn't know what to do. And she got a third revision on the left side with iFuse. So to the pictures, this was her preoperative MRI, so almost total normal MRI for her age. This was the right recess. This was the first one we did. So this was the postoperative CT scan. And what you see that I did not do a good job of grafting the recess in the upper part here, because there is no bone. There's only bone inside and beneath the implant. But you see a good distraction compared to the preoperative CT scan, and also the vacuum phenomenon is not there again. So this was the postoperative X-ray, and the CT scan 22 months postoperative show a moderate subsidence into the ileum, but it shows fusion around the implant. And comparing it to the CT scan postoperatively, to show you the subsidence, you see here the trajectory now down the iliac corridor, and you see it here like it was postoperatively. So we had some kind of subsidence of the implant in those 22 months, but we have a fusion. So preoperatively on the left side, like I told you, almost 1.9 centimeter or diameter recess. I did a good job, I think, with the implant positioning and the grafting, better than the other side. But 9 months postoperatively, we saw here bone resorption. We see lucency around the implant, and we see a reappearing vacuum phenomenon that you don't see in the postoperative pictures anymore. So this was after the first revision. This was 16 months after the primary operation. And you see again 9 months after the first revision, resorption of the bone, lucency around the implant. And we did the second revision now with BMP. This was the post-operative CT scan with a revision implant, again 21 millimeter, and again 11 months post-operatively. The same thing, bone resorption, lucency. Then I sent her away and sent her away for IFUs. This was an X-ray done after the third revision. And now we have 7.5 years after fusion of the right side with the Diana implant. And you see here, nice fusion of the right side. And you see also 12 months post-operatively of fusion and grafting of the recess. Here also a good bone integration and fusion of the left side. So lessons to be learned: fusion can be possible even after moderate subsidence, like we saw it on the right side. But on the other hand, the wider the recess, the harder it seems to be for the body to vitalize this large amount of allograft, even under the use of BMP. And the use of IFUs together with grafting of the recess can also show a solid fusion of the SI joint. Case 2, it was a surgical nurse of my hospital. She was a smoker. She was 44 years old when I did the first operation, the first SI joint operation. Before we did a fusion L4 to S1, and afterwards, after a couple of years, she had bilateral SI joint pain accentuated on the left side. Then we, of course, fused first the left side in 2013 or almost 2014, also together with BMP, and she did well. She was a slow healer, even with BMP, but remember, she was a smoker. But then we did the right side, and this went really down the drain. So in 2018, we did the first revision. Oh, not we, but I sent her away because I had learned from the first revision of this big Diana implant, 19 millimeter, and in this case we also had a 19 millimeter implant and a quite big recess, and I sent her away for the first revision, but this also did not heal, and they needed to be done a second revision again with 2 additional IFUs implants. So these are the MRI pictures before the SI joint fusion, after the fusion of L4 to S1. This is the preoperative CT scan. So vacuum phenomenon, sclerosis, everything you need to see. This is the post-operative CT scan of her left side. Not so good preparation below the implant again. This was the post-operative X-ray, and 8 months post-operatively, she was pain-free. But like you see here, there was again resorption of the bone in the upper part of the recess. In the lower part, I didn't bring in a bone, but the bone I brought in the upper part of the recess was resorbed. So I said, what is this? She's pain-free, and I don't see good fusion. So, but let's wait and see. She's pain-free. Why should I do something? She decided to do the other side. So this was a 90 millimeter implant, like you see here, big recess. And this was the CT scan then 47 months post-operatively on the left side, after we did the post-operative CT scan of the right side. And you see now here, compared to the 8 months post-operative CT scan on the left side, where you saw this resorption of bone, you see here again growing bone, and now you see a fusion of the joint. But now to the right side, this was the post-operative CT scan of the right side. Good position, good grafting, 19 millimeter implant. And you also see then after 7 months, unluckily, a resorption of the bone and a reappearance of the vacuum phenomenon that was not there in the post-op CT scan. Sorry. So I sent her away, like I told you, and 10 This was the first revision 10 months after the Diana implant. And now you see that 2 out of 3 of those I-fused bolts are not inside the joint. Only the left is, here, this one is inside the joint. The other ones are going through the recess and should be settled a little bit lower inside the joint. And you see that this one is going right through the recess, and those 2 run through the recess. So she was in pain again, and there was a revision done, and 2 more I-fuse dowels were added. And this is the CT scan after 11 months of the second revision on the right side, and you see a good bone ingrowth, but you see that one of those additional implants also missed the joint, but she did well also on this side, and this was 6 years after the left side, and you see total fusion even inside the joint here now. So lessons learned. On the left side, even after almost complete resorption of allograft, fusion can take place after many months. We see this in a lot of cases. And again, in case of a huge recess, it is quite hard to place I-fuse rods correct into the small joint space because you have a huge recess and therefore a small joint, or in many cases, a smaller joint. And then, of course, it's quite hard to place those I-fuse rods. So now some of my better revision cases. A male patient, 49 years. He had an SI joint fusion with a Diana implant elsewhere and had ongoing pain radiating down to his knee. And he came, we did CT guided infiltrations and confirmed it really was again his SI joint. So we decided to do a revision in 2014. This was his preoperative MRI, a little black disc, a bulging disc in the midline, maybe an annulus tear. This was his preoperative CT scan with a not properly placed implant. It was too low and too lateral, and the grafting was also not done properly. So this would be the correct position in all the 3 planes. So we did a revision. This was the post-operative revision X-ray. And now you can compare the preoperative CT scan with the post-operative CT scan. And here you see proper implant position down the iliac column. And here you can see the grafting of the defect from the first Diana implant. 10 months post-operatively, again, some kind of resorption of the bone, but patient is doing well. And then 15 months post-operatively, another CT scan that I made because I was not sure what will happen to him. The implant might get loose, but it went the other way around, and now you see here fusion 5 months later than the other CT scan. And 38 months, another CT scan was done, and you see here also again a good fusion of the sacrum against the ilium. Lessons learned: correct preparation, implant position, and grafting is crucial for fusion. And like we see in many cases, that fusion of the SI joint takes really a long time. So the second case of the better revisions, male patient, 72 years, hip replacement before on the right side, and a 360 degrees fusion, L5 is 1. That was also not done in our hospital. And he had an SI joint pain on the right side. He had a severe osteoarthritis also on the other hip. joint, not on the right side, but on the left side. And he came again for examination and CT guided infiltrations, and we confirmed the SI pathology, and we did an SI joint fusion. In 2012, intraoperatively, there was a very severe osteoporosis. So 8 months later, I had to revise him, and I will show you why. So this was his preoperative X-ray, and you see here this osteoarthritis on the left side. And of course, you see also here the fusion that was done somewhere else. And in the preoperative CT scan, you see that the S1 screw is not in the way or in your corridor of the recess or of the preparation with the Diana implant, but you have a very narrow and shallow recess. So this was the X-ray postoperatively, and it was not very well placed. This would be the correct trajectory and position of the Diana implant. This is the CT postoperatively, and you see what I did wrong. Because of the osteoporosis, I went too far into the ilium. I lost my way, and the implant is almost totally inside the ilium and not inside the recess. Might be also due to the fact that it was a very shallow recess. So this would be the correct position, like you see it here. So this was the CT scan 6 months postoperatively. Patient, of course, still in pain. You see there almost the cortical bone forming again around the implant. And we did the revision, and I placed it now in the correct position and did a good grafting. This was the X-ray before the revision, and like I told you, this would have been the correct position, and now you see the X-ray after the revision, and it almost is matching with the left picture. So CT scan after 13 months, you see quite good bone formation and good fusion in and around the implant, and after 45 months, still a good fusion, solid fusion of the implant. Then he got a hip replacement on the left side, and then he was fine. So lessons learned: always verify preoperatively if the S1 screw is in your corridor, if it's an obstacle or not. In this case, it was not. And in patient with severe osteoporosis, you have to be very, very careful with preparation. And I did many of those surgeries, and so I can say I'm a little bit experienced. So, but also in this case, I made a mistake with the preparation. The last case, it was a female patient from Uganda, 40 years old. Had SI joint pain on the right side since many, many years, radiating really down to her foot. Had a possible Bertolotti syndrome due to a lumbosacral transitional vertebra, Castelli type 2B. I will show you pictures. And she had an SI joint fusion done in 2016. And because of recurrent pain, she came back and we had to revise her. And I also resected her, or partially resected her transverse process of the 5th lumbar vertebra. So this was her total normal MRI. Preoperatively, this was the Castelli type 2B on both sides. This is her preoperative CT scan. And this is the postoperative CT scan, and you see good grafting, good trajectory, good distraction compared to the preoperative CT scan, like you see it here in this picture below in the middle, and also the good grafting around the implant. So this is postoperative X-ray, totally normal. This was the CT before the revision. Subsidence of the implant into the ilium, like we saw a little bit lesser in the first case I showed you, and resorption of the allograft, lucency around the implant, especially on the sacral side, and joint space collapse compared to the postoperative CT scan where you had a correct trajectory and a good distraction. So now I put in a different implant. This was something I designed, and she asked me to operate her with this new implant. It's kind of a cage you can put inside the recess, and it's connected with an S1 screw via a rod. So these are the intraoperative pictures. And this was the X-ray that was done after the revision, and this was the CT scan after revision. Of course, this implant is not designed for revising a Diana implant. That's why you have here some room on the base of the cage, but you see here a good contact to the sacral and the iliac bone below or in the lower part of the cage. This is how it should look like in a primary case. So it fills out totally the recess, and it has a good contact on the flat iliac side and the concave sacral side, and you can also graft it. But she did very well after the operation. She has almost no pain anymore, especially almost no pain radiating down to her foot anymore. What I'm missing is now a CT scan after 1 year, but hopefully she will come back from Uganda that we can do it. So lessons learned, lumbosacral transition vertebra does not interfere with the posterior approach, and Bertolotti syndrome can be addressed together with the SI joint fusion via the posterior approach, for example, with a Diana or Nadia implant. Implant subsidence is possible even in a young, bone-healthy patient, and maybe some kind of cage-like implant or implants are better for the recess than a round implant. We have to wait and see. So thanks for joining, and now you can ask questions.
I have a question. When you do a revision, do you ever check cultures in your operative site for a silent infection?
What do I check?
Cultures. Do you culture the bone looking for a Staph aureus or dermatitis infection, something like that?
Not usually, no. Even only if I have
started doing that.
Only if I have a suspicion.
Yeah, I've started doing that for all my revisions. I have yet to find a positive culture, but my orthopedic colleagues tend to do that with their failed fusions. The other people that deal with fusions?
So Tom, there's some data that if you're going to do that, the folks from Mayo have shown that if you do sonication of the implant, you get a higher yield of bacteria. And the question becomes symptomatic versus asymptomatic infections versus colonization, and that whole difficult discussion. And so I guess I'm sort of in Volker's camp that if I see that SI joint lucency, then I worry about it. If I don't see the lucency and they have a normal C-reactive protein and SED rate, I guess I have not routinely cultured the implants.
Mm-hmm.
I'm sorry, what bone graft did you typically use? Allograft or autograft or a blend?
We use allograft from former hip surgeries. So it's from a bone bank. They're demineralized, and then we just break them down to small pieces. And in most of the cases, I use almost one head for filling up the recess, one complete head.
And the extra-articular space where you're going is about 2 centimeters, typically?
Larger. 2 centimeters? What do you mean with 2 centimeters?
You said it's about 20 millimeters, right? Is that the size of the space in the where you're doing your fusion?
In some cases, yeah. In this lady, it was a very huge recess. It could be very small, you know, that you only can use a 30 millimeter implant, and then of course you don't have to use so much bone or so much allograft. These were cases with a huge recess, you know.
Right. What's the average, you think?
The average, I would say around 9 to 11 millimeters.
9 to 11. Yeah, the obviously the intra-articular space is about 4 to 5. So, you know, that's what's the advantage of intra-articular fusion. Are many, I think, and one of them is you have a smaller distance, and clearly the bone is more dense under compression in the articular space versus the recess where it's really under tension, so tends to be not as dense bone.
Yeah, maybe you're correct. I don't know the density in the cartilage-bearing joint, but it makes sense what you're saying. You know,
maybe you have an app for your Hounsfield units that you can look at. But when I was looking at a lot of your scans, I could see that difference, so you don't have as much concern about subsidence. But I think the intra-articular region, there's less osteocyte jumping distance and earlier incorporation, so fixation doesn't have to be as secure because the fusion should happen faster, which is usually what we see under compression anyway.
But the problem, I think, of the subsidence is the round implant. You know, we saw this also with the cages that were round, where we used them in spine surgery. They also subsided through the end plates, and you have just this small contact area to the sacrum and to the ilium. I think a flat or a more flat-like implant, like a cage, would be the better option for the recess. So this is my personal opinion. Just an opinion.
Well, if I remember the cases you presented, what was your fusion rate for the extra-articular cases like you're describing?
For the Diana implants in the German civilian study,
right,
we had a little bit over 30% only about of fusion cases, but it was also the case that many of the implants were not positioned well, and also it was the fact that we just did a CT scan 6 months after the operation. And like you saw in those cases, fusion takes sometimes place in between the 6 and 12 months or even 15 months after the primary operation. So this might have been too early for confirming CT scan while we did this study.
Volker, that was a wonderful talk. In our experience, we used BMP and had about an 80% fusion rate, and the ability to revise it was useful for those that did not fuse. And I think other things contribute to it that you didn't mention. When you impact the bone, if you impact it too hard, you get what David Polly calls a bonoma. You know, with
no, I don't impact it too hard, because this was what I saw in some CT scans where you just had almost a white clot of bone graft or some bone-like graft where it was so dense that no cell could even come into and to vitalize this. No, I just break it up in quite rough pieces, and then I compress it, but I do not use a hammer or something like that. I just use my hand and compress it with hand pressure.
Yeah, I've made that mistake of impacting too much and getting some avascularized or non-vascularized bone. And when I revised it was clearly just a bunch of non-vascular bone. So that's another piece of variability that can happen with the posterior approach.
And the size of the recess, in my opinion, is also a problem for vascularization.
Yes. Any other?
Volker, can I ask you a question? I've had the opportunity to revise a couple of well-positioned implants that were fully ingrown and had what I would call an extra-articular arthrodesis. It was the lateral recess with solid bridging bone, but the CT-guided injection in the caudal aspect of the joint still reproduced the pain. So have you seen that phenomenon? And it reminds me in spine surgery of people who had a solid posterolateral arthrodesis, still had discogenic pain, and an interbody fusion then subsequently relieved their pain. And so that concept of insufficiency of the bone to handle the load transmission is my explanation of the pain. I'm curious if you've seen that phenomenon.
Not in my patients. What I have seen is facet joint problems on the operated side. L5 is one facet joint problems, not or quite a lot, I have to say, but not really pain that is coming again from the joint. If I have a real fusion shown in the CT scan and no vacuum phenomenon inside the joint, because if you think you have, I don't know if you have looked up if they still had a vacuum phenomenon in the joint, because in my opinion, you don't see every time solid fusion, or you think you see a solid fusion in the recess and around the implant, and you still have a vacuum phenomenon in the joint. And this is for me, or gives the idea that it's not fused. You know, maybe those patients, maybe you look them up again, maybe they had a vacuum phenomenon, but can you say that they were really fused?
I have a comment on that if you are interested.
Andreas, hi.
Yeah, I've done about 270 iFuse surgery or SI joint surgery. The first were Diana, and in the beginning we put the iFuse implants on a straight line in the back of the joint. Then we found that quite a few patients still had pain, and we did intra-articular injections. And if the pain was relieved, we put an extra implant in front of the dorsal implants, and quite a few of those patients had pain relief. So I think you can have fusion in the back of the joint and still movement in the front of the joint and still pain from that. So what you really need is a complete stability in the complete joint. So you have to have some kind of stability in front of the joint and some kind of stability in the back of the joint to reveal pain. You talked about cartilage pain. I think I don't know. I think it's more about stability throughout the joint.
That's why I'm looking for the vacuum phenomenon, because I think there's, if you see it, there's still movement there, you know.
Exactly.
Okay, well, that was a very interesting discussion. Once again, to remind everybody, our next symposium will be on September 9th, talking about difficulties with lateral surgery, and David Polly, along with Vic Patel, will be our speakers. And if anybody has any other topics they would like to have SIMEG address in this type of forum, please let any of us know and we'll pass it on to the board. Are there any other thoughts? Okay, thank you very much, everybody.
So Tom, can I just suggest on thoughts, one of the things that Victor brought up a little bit was sort of order of surgery, and certainly in spine with spine deformity, whether you do the hip or the spine first is a big topic of debate right now in the United States, and I think elsewhere in the world. And so the patient who has concomitant hip disease, spine disease, and SI disease, how are people thinking about the order of interventions for those patients would be potentially useful discussion. I'm not sure there's much information about it yet, but at least this is a critical group of thinkers who may want to provide some insight in that regard.
Excellent. Okay. Thank you very much, everybody.
Thank you.
Thank you.
Bye-bye.
Bye.
And I'd like to thank our speakers. That was just a wonderful conversation.
Well done. Yeah.
Thank you.
Thank you very much.
Great day.
Bye-bye.
Thank you.